question, think about what's happening, think about what cell types you're seeing in your patient. Okay, so the leukemias, that's kind of where they fit. Once you make the diagnosis for the patient, then it all becomes safety about what their care becomes, because they go on that aplastic isolation that you're taking care of patients. And then we kind of treat stuff symptomatically, but it's all about safety. No fresh foods that have peels. No flowers in the room because the water can grow bacteria. All those things are there. Hand washing is key to taking care of these patients. It is none of that walking in the room and doing, you got to wash your hands every time you encounter the patient. Every time. And if you go to Moffitt and visit patients who are doing in the oncology areas, they actually have a sink for you to wash your hands before they even let you inside. That's how seriously we take about making sure that everybody who comes in there, including nursing staff, every time you go outside the unit, you have to wash your hands before you come back in. Because that's how important it is. Because little thing for you is no problem. Little thing for them that can't fight infection can be overwhelming sepsis. Okay, so that's the issue that you worry about for those patients. Then we had the lymphomas in there, so that was the Hodgkin's, non-Hodgkin's. Okay, so out of the lymphomas, if you had to have one, Hodgkin's is the better one to have, has a better cure rate when you're talking about 5 years out. But this also is, this one is lymph node enlargement, just like the leukemias. That's what I'm saying, they sound a lot alike together. But when you're talking about this patient who has Hodgkin's disease, you don't see the things going on in bone marrow. It's a problem in the lymph system. So when you actually see patients, they have a nodule, or I should say a nodule because it's a lymph node, but it's enlarged. And things that are painless and fixed, meaning they don't move around, are usually malignant. Hard, painless, and are fixed are things that are usually associated with malignancy.
So are both painless?
For if you have malignant things, they don't hurt. Things that are infectious hurt. So if you have a lymph node that's painful, red, tender, those types of things, that's usually infection. The opposite is going to be present for patients who have things that are bad. So doctor's going to do a biopsy of it, see what the cell type is, see if it's something that's cancerous. And like I said, if it's not hurting you and it's just sitting there, more than likely it's something that can kill you. So doctor's going to do your biopsy, tell you what the cell type is, see what it's sensitive to, meaning whether it's sensitive to chemotherapy or radiation, or both. Because those things are important. What they try to do is, whatever it's sensitive to, and why I keep saying whether it's radiosensitive versus chemosensitive, is that if it's something that can help shrink the size of a tumor, you do that first. Because if a patient's going to need surgery, you want the smaller tumor to resect. So that's why they look at it as something that's more sensitive to chemotherapy versus radiation. Because whichever one it's sensitive to, I want to do that one first. Because that means I should shrink the size of tissue, because that way if I make a tumor really small and then give you chemotherapy, that should clear up the problem. That's what they're, in their essence, that's what they're thinking about when doing those therapies. They used to do them both together, and then we found out that we cause more of a problem for patients. So now you see one versus the other. They may be in quick succession, but they do one first and then the other. Once they find it, figure out what it is that they're dealing with, they also, one of the other parts they do as far as the diagnostic piece is look for different areas where you may have lymphadenopathy going on. So you see other lymph nodes that are enlarged in the chest. Because if you look at the pictures of the girl in the book, she has a few nodes up here at first, and then you look a little bit closer, she has nodes up there, and then she has them on her clavicle. And you look a little closer there in her chest, and then you see them all the way down to the abdomen. Those are things that are talking about staging and where it's located. If you see staging in a question, it's asking about survival rate. I'm not asking you where the location is. Stage 1 and 2 are the cancers that are, when you talk about patients that have Hodgkin's disease, have the best cure rates. Stage 1, of course, you know is the best because that's the smallest one. But stage 2, if you can get a person at stage 2, those have the highest, stage 1 and 2 have the highest cure rate when you're talking about patients who have Hodgkin's disease. 3 and 4 are more problematic. Also, you have to ask the patients about if they want to have their own children, because anything when you're talking about stage 4 is down here. So if that means the patients may need irradiation over the pelvic area, you have to harvest eggs and sperm to see if they want to have their own kids. And if you look at this one, when you're looking in your book, you see that this happens in a lot of young people. So that's why it's a big issue as far as talking about counseling, family counseling, because it may be something that they don't think about at their age, but it could be something that comes back later in life if you want to have your own children. And also one of those has a significant cell on biopsy. That's that Reed-Sternberg guy. All right.
That's the one.
So those are things that will help you kind of remember what's happening with your patients. Then you have multiple myeloma, which was a plasma cell problem. There's something that happens in the plasma cells that replaces bone marrow matrix with a Swiss cheese appearance. So it looks like it's been eaten through. And those patients actually have pathologic fractures a lot of times. They also have hypercalcemia, because remember, bone is demineralized. One of the places where calcium is in your body is in bone. So you see a high calcium rate. And what also happens when they have a high calcium rate, something else happens in the body. That calcium doesn't just stay in your blood. They get stones. So a lot of times you'll see kidney stones associated with these patients as well. So they end up having renal dysfunction. Those are the kind of things you see with this person. The other thing behind that renal dysfunction piece is that Vince Jones, 2 other guys, all right, that came along and talked about these large cells that come along that actually are excreted in the urine. It's a protein cell, but it actually breaks down the kidneys. So that's why they go into kidney failure. A lot of times patients will tell you things taste metallic or taste like aluminum, that kind of stuff. And that's one of the things you start looking for. That's an odd complaint, but it's something that's commonly associated with patients who have multiple myeloma. But because their plasma cells, I mean, there's bone marrow has been taken over by these abnormal cells, they really do have problems the same way you would with a leukemic patient, but it's a different process. Their H&H is low because this has been taken, the bone marrow has been taken over by this process. So they may also need a transfusion. Multiple myeloma is also a disease process that can be treated with chemotherapy and a bone marrow transplant. So that if the patient does need a bone marrow transplant, or they're thinking that's part of care, you try to hold off on giving transfusions. And that's for leukemic patients as well. Anytime you give a person a transfusion, they create antibodies. So typing crossing you for a bone marrow match gets harder the more transfusions you take. So they try not to do them unless they have to. You may have a patient who's on, and when you talk about patients who have multiple myeloma, the treatment is steroids, electrophoresis. They're putting blood through to have it, try to clean out some of these cells that are associated with the multiple myeloma process. They usually do that for 10 to 15 days. And they try to see if you have an improvement of symptoms associated with that. And usually if there's, at this point, if they're going to do chemo or for the patient, they started at that point. But they try not to transfuse the patient if they're going to do a bone marrow. Because not only that, is that a lot of times because these people are in renal failure, they also need a kidney donation. So you sometimes see patients go on hemodialysis for a period of time. It can have some return of normal function of the kidneys, but they will always be impaired. So they usually suffer from renal insufficiency still, even if they get better to that point. But bone marrow is something that can be done. This is my sister-in-law had this particular disorder. And her thing was is that she went to the doctor's office because she just was feeling bad, kept feeling bad, and couldn't figure out what was wrong. And just went for it. She says, finally I made myself go. Now she worked at USF at the time, so you can go to USF Medical Center because it's part of your thing. But she just didn't want to go to anybody. So she goes and she gets her lab work done because she's pre-op, because she's complaining a lot of GI stuff. Goes to the doctor, and when they call her at the office, call her from the office and told her she needs to go to the hospital. So then, of course, she calls my mother, and my mother calls me. to tell me that she says they told her to come to the hospital because her creatinine is 12. And I said, who? And you know, I'm like, what? She's not, what are you talking about? So I'm thinking, I said, Ma, you sure it's not 1.2? And she goes, no, she told me 12. I said, was she on her way to the hospital? She said, yes. I said, that's a good thing. She needs to be there. Because I said, her kidneys aren't working right now. And that was her presenting symptoms. As she said, didn't feel well. She ended up going to the doctor. Creatinine when she went was 12. Her BUN was 114. And I was like, I don't even know how you still walking around, kind of thing. But she was. And when she went to the doctors, they were doing her diagnostic stuff. And of course they do. When you see crazy stuff like that happen, you get a lot of consults at the beginning of your hospitalization. And one of the doctors came in the day he told her that she had multiple myeloma. I was actually there, and I was trying to get out the room so quick because I didn't want to know what it was. You know how you just know that it's not right and it's not going to be a good thing? And so he had said he was going to start plasmapheresis the next day, so I already was like, oh, that's not good. Because those are things like Guillain-Barré. It's odd stuff that you do plasmapheresis for. And then he said, you had this protein in your urine called Bence-Jones, and I knew what it was for sure. And so he kept talking to her, and then he left the room, and she looked at me and she said, it's bad, isn't it? And I'm like, yeah. You know, I don't ever want anybody telling me about nobody's disease process in the room kind of thing. Let me freak out about it outside and then come back and talk to you and make you assured. But if he's saying that, there's no way you can really just go like, well, no, everything's fine. Because it's not. You know, you have to go through this. Now, she went through some time. Her and my mom were sick about the same time, so they both got real small together because I told them they were smoking crack together. And they just didn't tell us that they were doing this because I call them the crack sisters kind of thing. Because they got really small, both of them. And but she ended up getting she went on dialysis. She was on dialysis for probably 2 years. But she had a bone marrow. And she's been disease-free now for 6 years. So she's considered cured, thank goodness. But still, those are, anytime something happens, though, it freaks you out. She's always worried about when something happens or what I need to do now. And I said, it's going to be okay. It's hard to kind of think about it because something can happen all the time, but you can't live your life always worried about the next shoe to drop kind of thing. Just live your life kind of thing. So it is something that happens. You can have people with multiple myeloma who have a relatively non-aggressive course. They just kind of go along, live their life, all the way up to a person who's acutely ill, and you don't know whether they're going to make it. One of my clinical instructors right now, his mom is one of those with the aggressive type of multiple myeloma. That is, he's one of the ICU clinicians at Tampa General, and he was dealing with that for this last semester. So just know that you can have people that live their long, happy life kind of thing, all the way up to the person who's acutely ill, who has a lot of problems that's kind of associated with that. But that's the multiple myeloma piece. The other thing that you have, which is quizzy time, is septic shock. Okay, so that's one of those things. Did I show you all the sepsis video? I think I did. That shows you things you're supposed to do for your patient that has sepsis. The sepsis back video. Did I show you all that?
No.
I'm retarded. I don't even know what class I'm in anymore. So I got to start doing 13 jobs to figure it out. So there's a video that shows you all the stuff you should do for sepsis. Now, one of the things is septic shock is one of those distributive shock things that you're looking at for your patients. The major thing to remember is any person that is septic or that you think has SIRS criteria, or you're talking about SIRS stands for Systemic Inflammatory Response Syndrome. That is the syndrome of symptoms that you usually see before patients develop overall sepsis. So you start seeing some things that start to change in the patient. And in elderly people, it's a little bit different than for your age, okay? One of the things to kind of always remember, a temp of 100 and 100.9 is like 103 for somebody who's 90 years old, because they normally don't have temps, okay? They usually just run it at normal or just below that, so they may be subnormal with their temps. For an age to be associated with a question about somebody with a temp has a reason for it being there. The older a person is, a low-grade temp for them is like having a fever for us. So that's how you have to think about it. What we want to do is, if you see those patients who are actually showing signs and symptoms, especially if they're elderly, because they don't always have the temp, so they have confusion, agitation, all those kind of things you see with hypoxia. But the other thing we want to do is draw a lactic acid level. Okay? So that's one of the things that you want to see. What is the patient doing as far as their lactic acid levels are? If it's high, we treat the patients as a septic patient. And you might have heard it in the hospital. They call it now, just like they do for a heart attack. They call it a sepsis alert. That means that the rapid response team is going to go evaluate the patient, make sure that we do certain things. And that was the reason I told you to go to the CDC website to look at that SIRS criteria, the septic criteria, because there's a bundle that goes with sepsis. Certain things you're supposed to do within so many hours of onset in the patient, because that is a core measure, is following that for patients who are in the hospital. So there's a little video that's on YouTube that will show you about sepsis treatment, and it's fun. Nothing is in nursing school is fun, right? But this one kind of shows you all the stuff about sepsis, and it does it in a nice way. Plus it has music. The thing about music and why it works so well as far as teaching goes is because if you think about it, stuff that you learn in music or stuff that you do with colors, you retain better. Because it's your brain works on it in a certain way. That's why when kids learn their alphabet, they do it by singing, because it helps them learn stuff. All right, so I'm going to show you this video about sepsis. You might want to turn that light out so y'all can see it.